from a series of interviews with users of the DOAC Dipstick.
I'm Philip Choi. I'm the clinical lead for stroke at Eastern Health. We are a large health service in metropolitan Melbourne with a primary and secondary catchment of over 1 million patients. So we cover a large geographic area. We see the code stroke is activated in our hospital about 1,200 times a year. Clearly not all those patients are proven to end up having ischemic stroke. And we thrombolize about 140 patients a year. And we are a primary stroke center. We send about 50 to 60 patients for a mechanical thrombectomy or clot retrieval, as the term is used in Australia. And the reason we got interested in the DOAC stick is that we have, from our clinical experience, seen some patients that we send for primary clot retrieval without giving them lysis. And the only reason of us not giving them lysis beforehand is the fact that they are supposedly on a DOAC. And we haven't got a reliable way to quickly determine whether they're actually on a DOAC or not. These are patients that typically have a large stroke. They are aphasic. It's hard to get any history from them or any collateral history from their family.
How do you test for DOACs in your hospital?
The plasma level takes anything from 20 minutes to 40 minutes to come back. I've been told by my laboratory that if they get enough pre-notification, they can do the quality calibration. The actual testing will only take them about 20 minutes. But more often than not, the actual turnaround time is 40 to 60 minutes. So in a situation where there's a large vessel occlusion, we do not wait for that. We just send the patient for clot retrieval. And I'm saying that is a situation that's just unique to our hospital, to my hospital in Melbourne, where it's quite close to a comprehensive stroke center. But there are a lot of primary stroke center where the travel time to a comprehensive stroke center is much longer. And you definitely would benefit from giving thrombolysis where it is where you're able to, and that will be when the dipstick is negative, because we know both from our studies and all the other studies out there that a negative dipstick is good enough for you to make the clinical decision on. The fact that you can still have stroke when you're on a DOAC, that is something that we see not very often, but we see it common enough. And for those patients, you don't necessarily have a large vessel occlusion that you can retrieve. And at the moment, we have very limited treatment options for these patients.
What role do the results of DOAC tests play in medical decisions?
I think just like all the clinical decision making, and in particular thrombolysis is about risk and benefit. So I think if we have a patient who present very early on after onset, even though the level may be high, as in more than 20, so around 50 or 100, that is, you still will consider thrombolysis maybe if the clinical deficit is big enough, or if you have actual clinical evidence of ischemic stroke, like a large vessel occlusion with corresponding severe deficit from the stroke. That will be different to a patient who present at 4.5 hours or 6 hours. You will probably want to demand a level that is very low or even absent for you to consider thrombolysis. And I think, if we move away from thrombolysis, even any patients who are on a DOAC and present with an ischemic stroke or TIA symptoms, at the moment, in clinical practice, we don't routinely test for it, and I have a big issue with that, because first of all, I think that really impede the research in this area, in the sense that if a patient who had a ischemic stroke or TIA and they weren't taking antiplatelet, we will prescribe antiplatelet. If they are on antiplatelet, we might change the antiplatelet. But if they're on a DOAC, then we assume they're on a DOAC. We don't even check, and then we say, well, there's nothing more we can do. So whether that is true is actually unknown, and without testing the true prevalence in patients who supposedly already on a DOAC and presented with ischemic stroke or TIA symptoms, without knowing objectively whether they actually have DOAC on board, we cannot further to refine the treatment for this group of patients, especially with all the other novel antithrombotics, the factor 10As and the like, that is being trialed in the market at the moment.
What advantages do you see in urine tests for the hospital?
The benefit of able to test the urine in the hospital is easily accessible. It is something that is not a foreign concept to the emergency physician. You test for urine infection is such a common test that no one would be unfamiliar with, and especially the way that we are reading the results of the dipstick is also very conventional. The pads and the arrangement and the color changes. So I see that as a huge advantage when we try to educate the doctors and nurses in regional areas, right? If a piece of equipment or technology is quite complicated, that clearly is going to be a problem. But when I first came across the DOAC stick, that is the ease of use, the simplicity of it, and the fact that it's a 10-minute turnaround time. You can take a photograph of the result even, so there's a bit of objectivity to it.